Hi, this is Dr. Perry Carpenter. I'd like to thank you for taking the time to join me on today's video. On today's video, I want to talk to you about a condition that we commonly see in the QME examination, particularly for those qualified medical evaluators that are involved with physical medicine, musculoskeletal, neuromusculoskeletal cases, and that is the conditions of spondylolysis and spondylolisthesis. And the reason I want to talk to you today about these two conditions is because number one is the AMA guides do provide for permanent impairment due to spondylolysis and spondylolisthesis. However, I get calls from many doctors who are sometimes uncertain as to how to provide for permanent impairment, if at all, for these two conditions. So I want to review a couple of key things about spondylolisthesis today with you. Number one, I want to give you just a little bit of background information on spondylolysis and spondylolisthesis, and this will just be a review for many of you, but I want to just go over a couple of anatomic facts so that we're all on the same page, at least for the purposes of this discussion. And then number two, I want to talk to you about physical examination findings for an active spondylolytic or spondylolisthetic segment of the spine. And we're going to differentiate between an inactive and an active lesion. And we'll use some of our physical examination maneuvers to help us differentiate between an inactive lesion and an active lesion. Once we establish that, I want to go into a brief discussion about the permanent impairment that the AMA guides provide for these two conditions. And then finally, because most references will tell us that both spondylolysis and spondylolisthesis represent pre-existing conditions. Now, of course, there are exceptions to this. The spondylolysis can be the result of a traumatic back injury, which certainly could happen in the industrial setting. But in the main, and for the most part, the incidences of spondylolysis and spondylolisthesis that we see are pre-existing conditions. So I want to review some of the apportionment issues related to providing for permanent impairment due to spondylolysis and spondylolisthesis. So this is going to be an excellent presentation that has analogy also to other pre-existing conditions, because as we'll talk about here in our next segment, this merely represents a pre-existing condition. And as qualified medical evaluators, this is not a novel situation. We're frequently presented with all manner of pre-existing conditions, and spondylolysis and spondylolisthesis are simply other forms or another form of pre-existing conditions. So we'll talk about how to handle that in your apportionment determination. So I want you to go ahead and take a minute now and retrieve your AMA guides. And I want you to actually go ahead and get your AMA guides, because we're going to be referring to table 15-7 in chapter 15. And I want you to actually lay your eyes on these passages as we go through these passages. I want you to see these passages with your own eyes so that we're on the same page. So I'll take a minute now and get my guides, and I'll meet you right back, and we'll begin today's discussion on spondylolysis and spondylolisthesis in the qualified medical examination. Okay, I have my AMA guides with me here now, and I hope you have your AMA guides with you as well, because I want you to lay your own eyes on some of these passages that we're going to review from the AMA guides. In addition to my AMA guides, I have another reference here that I've extracted some material regarding spondylolysis and spondylolisthesis from. And this is a textbook that's familiar to neuromusculoskeletal providers in general and radiologists specifically. This is Yoakum and Rose, Essentials of Skeletal Radiology, which has a whole chapter devoted to these conditions that we're going to talk about. So I've extracted some of my references for today's material also from this textbook. So let's talk about spondylolysis and spondylolisthesis. First of all, the terms spondylolysis and spondylolisthesis come from the Greek roots. The term spondy simply refers to vertebra. And then the term lysis for spondylolysis, lysis means a dissolving of or a dissolution of. So with spondylolysis, we have a dissolution of the vertebra. And specifically, we have a dissolution of the segment of bone in between the superior articulating facet of the vertebra and the inferior articulating facet of the vertebra. This is known as the pars interarticularis, and this is where we have a dissolution of the vertebra. We have a dissolution of the cortical and trabecular bone of the pars interarticularis, which then becomes filled in and infiltrated by fibrocartilaginous tissue, and we simply refer to this as a pars defect. So that's spondylolysis. The term listhesis means a slippage of. So with spondylolisthesis, we have a slippage of the vertebra. Now, it's important to note that we have two broad categories of spondylolistheses. Spondylolistheses. We have spondylitic spondylolistheses, and we have non-spondylitic spondylolistheses. And what this refers to is a slippage of the vertebra due to either a defect of the pars interarticularis, that's the spondylitic spondylolisthesis, and we have slippage of the vertebra, spondylolisthesis, due to other causes other than a defect of the pars interarticularis, and we refer to these as non-spondylitic spondylolisthesis. And we'll talk about some of the clinical presentations of each of these broad classifications of spondylolisthesis. Okay, so a couple of things I want to go over with you now. In the AMA guides on page 404, this is table 15.7, the AMA guides provide for permanent impairment for these two conditions, spondylolysis and spondylolisthesis, under the range of motion method of determining spinal impairments. And as we'll see here very shortly, spondylolisthesis can actually represent a crossover between the range of motion method and the DRE method. And I'll talk about that a little bit more here in our next segment. So in table 15.7 under section 3, the AMA guides provide for permanent impairment due to spondylolysis and grade 1 and grade 2 spondylolisthesis. And then also under a separate category, the AMA guides provide for permanent impairment due to grade 3 and grade 4 spondylolistheses. And we won't talk here about the grading system for spondylolisthesis, as I'm sure most of you are all familiar with the Meyerding grading system of spondylolisthesis. So, for example, under section 3, category A, the spondylolysis or grade 1 or grade 2 spondylolisthesis in the presence or accompanied by a medically documented injury that is stable and medically documented pain and rigidity with or without muscle spasm, this qualifies for 7% whole person impairment under the range of motion method. This is the diagnosis-based portion of the range of motion method. Recall that the range of motion method involves three components. Number one, a diagnosis-based condition, and for those we refer to table 15.7. Number two, any losses of range of motion that we discover on our digital or dual inclinometric examination. And number three, any neurologic deficits in the form of sensory or motor deficits. Typically we're referring here to the spinal nerve root deficits. And then under category B, the AMA guides state that grade 3 or grade 4 spondylolisthesis accompanied by medically documented injury that is stable and medically documented pain and rigidity with or without muscle spasm, this qualifies for 9% whole person impairment in the lumbar spine under the range of motion method. Now, I want to spend some time going over those definitions very carefully because it's contained within these definitions that the AMA guides give us some indication as to the cause of most of the spondylolysis and the spondylolistheses that we see. So it says that, let's just take category A. Spondylolysis or grade 1 or grade 2 spondylolisthesis that's accompanied by a medically documented injury. Let's just stop right there. So we have a spondylolysis or we have a grade 1 spondylolisthesis, and we find that that condition is accompanied by a medically documented injury. So the guides tell us right off the bat that if we're going to provide for permanent impairment due to spondylolisthesis, number one, there must be a bona fide and medically documented actual incident of industrial injury. Because many times these conditions, spondylolysis and spondylolisthesis, are asymptomatic pre-existing conditions. In fact, the AMA guides tell us so when they use the word accompanied by. They don't say that the spondylolysis is caused by a medically documented injury. They don't say that the spondylolysis is precipitated by a medically documented injury. They say that it's accompanied by a medically documented injury. That implies that these conditions coexist simultaneously and that actually the spondylolysis and spondylolisthesis typically pre-existed the industrial injury. And that's consistent with most of the citations in the literature, and certainly referring to Yoakum and Rowe's textbook of radiology, most of the references contained therein suggest that spondylolysis and spondylolisthesis generally represent stress fracture injuries that occur typically in youth, anywhere from 5 years of age up and through the teenage years, when children and teenagers are involved in repetitive stresses involving hyperextension of the lumbar spine. Most of the research suggests that this is when these pars defects and early grade 1 and even grade 2 slippages seem to occur. So the AMA guides acknowledge that by suggesting that the spondylolysis and spondylolisthesis merely accompany a medically documented injury. It doesn't say that they're caused by the injury. And it's my opinion, and I'm suggesting to you, that a pars fracture, a traumatic spinal injury that results in a pars fracture, is a dramatically different condition that presents to us than simply a pre-existing spondylolysis or a pre-existing spondylolisthesis. A traumatic pars fracture is going to cause greater disability, greater need for medical treatment at the initial onset of the injury, is probably going to require medical bracing and is a much different condition than the pre-existing types of spondylolysis and spondylolisthesis that we see sometimes coincidentally on our diagnostic studies. Okay? Now let's continue. The AMA guides say in footnote at the bottom of table 15.7, they go on to describe this phrase, medically documented pain and rigidity with or without muscle spasm. So let's elaborate on this a little bit. It says in footnote number 1, the phrase medically documented injury, pain and rigidity, medically documented injury, pain and rigidity in quotes, implies not only that an injury or illness has occurred, so in other words we need to have a bona fide incident of industrial injury, a bona fide injury, but also that the condition is stable as shown by the evaluator's history, examination, and other diagnostic data, and that a permanent impairment exists which is at least partially due, at least partially due to the condition being evaluated. Well, the condition that we're evaluating is spondylolisthesis. And the AMA guides require that in order to qualify for permanent impairment, at least some of the permanent impairment must be due to the spondylolysis or the spondylolisthesis. And that's interesting because much of the scientific literature seems to suggest that these conditions are generally asymptomatic and do not contribute to back pain. Now there are exceptions to this, but it seems in the literature that the overwhelming preponderance of the evidence in the absence of a traumatic pars fracture is that these conditions are generally incidental, coincidental, and asymptomatic and are not a cause of back pain and are not a cause of impairment. So that raises some interesting issues. If you're going to provide for permanent impairment due to spondylolysis or spondylolisthesis, and the guides give us authority to do that, it's a condition specifically listed. If you're going to provide for permanent impairment due to these conditions, you need to be able to demonstrate that the condition at least partially contributes to the permanent impairment. So how can you do that? How can you do that? How can you, within reasonable medical probability, demonstrate that the X-ray finding of a pars defect without slippage or slippage of a vertebrae with or without a pars defect, how can you, within reasonable medical probability, demonstrate and document that that condition, at least partially, contributes to the permanent impairment? Well, we'll talk about that in our next segment, and that raises a couple of interesting topics before we conclude our program. Since the AMA guides suggest that the spondylolisthesis has to at least partially contribute to the permanent impairment, that sort of implies or suggests that apportionment is going to be an issue. Because if the permanent impairment is not due 100% to the spondylolisthesis, in other words, it's only partially due, or at least partially due, to the spondylolysis or spondylolisthesis, that suggests that other factors also contribute to the permanent impairment. So in our next segment, we'll talk about how to identify an active spondylolysis or spondylolisthesis that does contribute to the permanent impairment. And then once we establish that, we'll talk about some issues related to apportionment of this condition. Okay, so let's continue. So I want you to imagine the following scenario. You have a examinee in front of you, and you're familiar with the examinee's medical records, and you're familiar with prior diagnostic studies that have been obtained in this case. And you've determined from your review of the medical records, and possibly even review of the diagnostic studies themselves, that the examinee has either a spondylolysis or a spondylolisthesis. Let's just say, for purposes of this example, that the examinee has a grade 1 spondylolisthesis. And you're now at the permanent impairment examination, and you know that the AMA guides do provide for permanent impairment due to spondylolisthesis if the spondylolisthesis, at least partially, contributes to any permanent impairment that the examinee may have of the lumbar spine. And we'll concentrate our discussion here today on the lumbar spine. Although these conditions also manifest in the thoracic and cervical spine, let's just limit our discussion here today to the lumbar spine. Well, that brings up the topic or the concept of the active versus the inactive spondylolisthetic segment. Active versus inactive. And most references seem to suggest that these lesions are actually not active. They're not symptomatic. They're simply coincidental findings. So if you're at deposition, a sharp defense attorney could question you on your permanent impairment determination and your apportionment determination if you provide for permanent impairment due to either spondylolysis or spondylolisthesis. A sharp one will. So I'm recommending that you be prepared to handle it and that you evaluate it correctly in the first place. So let's talk about how to do that now. Now, an active lesion can be only definitively identified with diagnostic studies, and the SPECT bone scan is the most sensitive and the most accurate diagnostic study that we have for the identification of the active spondylolysis or spondylolisthesis. But there are some other things that we include in our physical examination and in our other radiographic examination that can suggest, within reasonable medical probability, especially when multiple findings are taken collectively, that suggest an active lesion versus an inactive lesion, in which case that condition qualifies for permanent impairment. So first of all, on physical examination, simply by inspection of your examinee, you may see, and these are not pathognomonic findings and they're not present in every case, but in an examinee with bona fide lower back pain, with an active lesion, active spondylolisthesis, you may see hyperlordosis of the lumbar spine. That would be something that you would identify by inspection and or palpation. You may see a functional scoliosis. A functional scoliosis. A functional scoliosis is a non-rotary scoliosis. It's a scoliosis that disappears on trunk forward flexion. This is the so-called Adams maneuver. So that's a functional scoliosis. You may see a functional scoliosis away from the site of pain generation. On physical examination, on prone palpation, you may palpate what is referred to as a step defect. Now, a step defect can be both a step up spinous process and a step down spinous process. A step up spinous process, meaning a spinous process that is more prevalent, more pronounced, more palpable, more so-called sticky outy, more sticky out in the posterior direction, a step up spinous process, that would be suggestive of a spondylitic spondylolisthesis. listhesis. As the spinous process and the neural arch is left behind and the vertebral body migrates anteriorly, which accompanies all the remainder of the vertebral bodies of the lumbar spine. So this spinous process is left behind and it sticks up to palpation, a step up defect. Now you can also palpate a step down defect in cases of non-spondylitic spondylolisthesis. This is typically found in older persons and persons with other radiographic findings, such as disc degeneration and also facet joint arthropathy. So in non-spondylitic spondylolisthesis cases, the vertebrae in its entirety migrates forward, and as it migrates forward, the posterior elements come along with the vertebral body, and that spinous process then disappears under your thumb, and it's a step down defect. So heighten your awareness towards the presence or absence of either a step up or a step down defect on prone palpation. On physical examination maneuvers, there's a couple of maneuvers that when they're positive, suggest is the best they can do, is suggest the possibility of an active lesion. And that is, number one is the Stork test, also known as the single leg standing hyperextension test. So to perform this maneuver, you have the examinee stand first on one foot and then on the other foot. And as they're standing on their one foot, you have them lean their lumbar spine into hyperextension. And this unilateral weight bearing and loading through the lumbar spine can light up an active lesion at the pars interarticularis if there is an active lesion present. Now you would then repeat the maneuver on the other side. Now there are other structures in the vertebrae that can be responsible for producing pain on this maneuver, so this maneuver is not pathognomonic for an active spondylolisthesis, but it can suggest an active lesion in the presence of other findings as well. So that's the Stork test, the single leg standing hyperextension test. That's a weight bearing test. Now a prone physical examination maneuver that we employ also that can suggest an active spondylolisthesis is known as the pheasant test. The pheasant test. So with the pheasant test, the examinee lies prone on the examination table. The examiner flexes the lower legs at the knees to bring the heels of the examinee towards the buttocks of the examinee. It's kind of like an Eli's heel to buttock maneuver, but it's done bilaterally. And it's done with slight overpressure to introduce hyperextension into the lumbar spine. So the examiner applies pressure to both of the examinee's lower legs to drive them close or to in contact with the examinee's buttocks. Simultaneously, the examiner uses his other hand to apply posterior to anterior pressure on the lumbar spinous processes. Now, this is particularly valuable if you're able to apply the pressure directly to a step defect, either a step up spinous process or a step down spinous process. What this maneuver does is it introduces hyperextension, not just extension, but hyperextension into the lumbar spine. Now, this is a non-weight bearing maneuver, but in the presence of an active and hot and symptomatic spondylolisthesis, one that's contributing to permanent impairment, this could produce a positive report of pain in the examinee, and could also produce other positive objective findings, such as a jump sign, a flinch sign, such as a yell, such as a groan, such as a wiggle, or some other indication of a true positive objective finding. Simply a report of pain on this maneuver does not constitute a true positive objective finding. Okay, so there's some physical examination observations, palpation procedures, and examination maneuvers that, taken collectively, and again, no one finding is pathognomonic for this lesion, but taken collectively, these findings could contribute to your conclusion for an active spondylolisthetic segment. Well, we then turn our attention to diagnostic studies. And for the evaluation of an active lesion, an active spondylolisthesis, we use lumbar spine flexion and extension radiographs. And this is where the range of motion method for the evaluation of spondylolisthesis crosses over into the DRE method for the evaluation of loss of motion segment integrity, because actually a spondylolisthetic segment, an active spondylolisthesis, is a segment of the spine that has lost normal motion segment integrity. An active spondylolisthesis is typically thought of as a hypermobile, unstable segment of the spine. We can determine this with our flexion and extension radiographs. Now, according to the AMA guides, translational motion of greater than 4 millimeters at L4, L5, or greater than 20 degrees angular motion at L4, L5 constitutes a hypermobile segment. And that could suggest to you that this is an unstable spondylolisthesis, in which case that qualifies as an active lesion. At L5S1, the AMA guides provide for 4.5 millimeters of translational motion and 25 degrees of angular motion. Measurements in excess of either of those at L5S1, we're talking about the movement of the L5 vertebra, would suggest an active and unstable L5 segment, in which case that would qualify as a active lesion, as an active spondylolisthesis, as an unstable segment, which would contribute to permanent impairment under both the DRE method and the range of motion method. Now, for the grade 1 spondylolisthesis under the range of motion method, this provides for 7% whole person impairment for the lumbar spine. Under the DRE method, this qualifies for much higher permanent impairment. I believe it begins at 25%. So it's up to your clinical judgment at this point which of the two methods most accurately describes your examinee's true permanent impairment. And that's a discussion beyond the scope of this video. Perhaps we can talk about that on another video. But I have, in great detail, discussed permanent impairment due to loss of motion segment integrity in other videos. So you may want to refer to some of those other videos, which are available on our website. Okay, so however, all that being said, the best imaging study that we have at our disposal for the identification of an active spondylolisthesis or an active spondylolysis is the SPECT bone scan imaging. SPECT bone scan imaging detects both physiologic and metabolic activity of the cortical and trabecular bone in the region of the pars defect, and radionuclide becomes concentrated in the pars defects, in and around the pars defects, and this shows up on bone scan imaging. So in this sense, the bone scan imaging would definitively provide your conclusion for an active spondylolisthetic segment in the presence of positive findings on physical examination, positive findings on radiographic flexion and extension studies, and positive clinical findings consistent with an active and symptomatic spondylolisthetic segment. Okay, so let's conclude that section on the permanent impairment. In order to qualify for permanent impairment, the AMA guides tell us that the permanent impairment has to be at least partially due to the condition being evaluated, which in this case is the spondylolisthesis. So I've given you several different ways and several different physical examination findings that you can rely upon to suggest that indeed the spondylolisthesis, at least partially, contributes to the permanent impairment. So if the spondylolisthesis, at least partially, contributes to the permanent impairment, what are some other factors that could contribute to permanent impairment in your examinee? Well, the AMA guides seem to infer, and they seem to agree with most of the research and literature that suggests that these conditions are typically pre-existing. Now, in that sense, a pre-existing spondylolysis or spondylolisthesis is no different than any other pre-existing condition that we encounter as qualified medical evaluators. We encounter pre-existing conditions all the time. In the spine, for example, we encounter pre-existing degenerative change. We encounter pre-existing anomalous configurations of the vertebra. We encounter pre-existing lumbosacral transitional vertebra. We encounter pre-existing spina bifida occultus. We encounter pre-existing calcifications of the iliolumbar ligaments. We encounter all kinds of pre-existing conditions, pre-existing injuries, pre-existing permanent impairments. Those are all pre-existing conditions. Spondylolisthesis, generally, in the absence of an acute traumatic pars fracture, which is a completely different animal, it generally represents a pre-existing condition. So if it's a pre-existing condition that at least partially contributes to the permanent impairment, how do you structure or fashion your apportionment argument in your qualified medical evaluation report? Well, it's really not that complex. It's actually quite simple. When it comes to providing your opinion on the apportionment of the permanent impairment and your determination of the approximate percentage of the permanent impairment due to the spondylolisthesis, in other words, the pre-existing condition, and the approximate percentage due to the industrial injury, we refer to the principles espoused in the Escobedo case. And the Escobedo case really gives us our framework and our ground rules for handling difficult issues of apportionment. Remember that with the Escobedo case, Marlene Escobedo worked for Marshall's department store, and she injured her left knee, I think it was, in either 2002 or 2003. And in 2005, the qualified medical evaluator provided for permanent impairment of her left knee, which had had an arthroscopic surgical procedure. And he also provided for permanent impairment of the right knee, which quickly developed symptoms after the original left knee injury as a compensable consequence due to limping around, favoritism, altered gait pattern, etc. So the original injury was to the left knee, and the compensable consequence injury was to the right knee. Well, when it came time to apportion the permanent impairment, the qualified medical evaluator provided for a large percentage of the permanent impairment of the left knee injury to be due to the industrial injury, and a small percentage of the compensable consequence right knee permanent impairment to be due to the industrial injury. And this became a precedent-setting case because it really pointed the spotlight to the mechanism of injury as a critical and pivotal fact upon which we rest our apportionment determination. Now, with the left knee injury, Marlene Escobedo was coming down some stairs and she slipped and stumbled and wrenched her knee, and I think she actually went down on the knee. In other words, she had a significant mechanism of injury. On the right knee, there was no mechanism of injury. It was simply due to favoritism, altered gait pattern, limping around a little bit because of the left knee. There was no mechanism of injury. This is what we term a minimal mechanism of injury. The right knee had a severe mechanism of injury. The left knee had severe mechanism of injury. The right knee had minimal mechanism of injury. Well, don't you know that both knees showed pre-existing degenerative change? There was loss of the cartilage interval, there was osteophytes, there was traction spurs on the patella, and all these pre-existing degenerative changes. Well, the qualified medical evaluator apportioned a large percentage of the permanent impairment of the right knee to the pre-existing condition, which was the degenerative change. And he only apportioned a small percentage of the permanent impairment to the industrial injury, meaning due to favoritism and altered gait pattern as a result of the left knee injury. And vice versa on the left knee injury. And the opinion was held up. The opinion was held up. After appeal, the judge determined that the minimal mechanism of injury on the right knee could only contribute to a small portion of the permanent impairment, and that any other person would not have suffered permanent impairment absent the degenerative change that was pre-existing in the right knee. And so when it comes to spondylolysis and spondylolisthesis, the same situation presents. It's simply a pre-existing condition that comes down to the mechanism of injury. Now, if you have an examinee who has a minimal mechanism of injury, almost no injury at all, let's just say there's involved with repetitive lifting of flour sacks or something like that, and the examinee comes up with some back pain. In other words, there was no specific incident, no specific onset, though it didn't fall from a scaffold, didn't have some tires fall off the rack at Costco and hit him on his back. In other words, the mechanism of injury was minimal. In those cases, the apportionment of the permanent impairment due to causation, the causation of the permanent impairment, is likely largely due to the pre-existing condition and only minimally due to the industrial injury. If the examinee suffers a severe mechanism of injury, such as falling from a scaffold, falling downstairs, having something land on him, well, that's the type of injury that could cause permanent impairment in any person, even without a spondylolisthesis. That's a mechanism of injury that more closely resembles the type of injury that could produce an acute pars fracture. An acute pars fracture. In that situation, with a severe mechanism of injury, you can confidently and within reasonable medical probability conclude that a large percentage of the permanent impairment is due to the industrial injury, and only a small percentage is due to the pre-existing condition of spondylolisthesis, which most references and most authorities agree is generally an asymptomatic condition anyway. Okay, doctors, does that make sense to you? So in that sense, a spondylolisthesis is not that unique of a cat and not that difficult of a situation to deal with. It simply represents, just like any other pre-existing condition that we find, it really comes down in the end, when we provide our opinion on the apportionment of the permanent impairment, it really comes down to the mechanism of injury. And that's the principle that was clearly established in the Escobedo case, and those are principles upon which we can solidly rely until something different or new comes along. So in conclusion, I wanted to speak to you today about spondylolysis and spondylolisthesis because those are conditions that we frequently encounter in the neuromusculoskeletal qualified medical evaluation. And like other anomalous configurations and unusual findings in the spine, spondylolysis and spondylolisthesis really only represents nothing more than a pre-existing condition. Our responsibility is to determine whether or not that pre-existing condition is an active lesion or is an inactive incidental coincidental finding. In the presence of an active lesion, the AMA guides tell us that that condition does qualify for permanent impairment. And when it does, we typically are going to have to address apportionment issues. So doctors, I hope you found this discussion helpful and interesting. For now, this is Dr. Perry Carpenter. It's been my pleasure to be with you here today. And I look forward to being with you on future videos. And for now, I'm wishing you best of success in your career as a qualified medical evaluator.